Sir, बोलिए
So,
sir. 1 minute, sir. I'm streaming live streaming it. 1 second. Yes.
Pawan,
Yeah.
Pawan, good afternoon.
Hello, sir. Welcome, sir. Welcome,
Welcome.
good
President,
afternoon,
sir.
sir. Welcome,
Yes,
sir.
sir.
Thank you, sir.
Welcome.
Sir, మిమ్మల్ని కూడా co-host చేశాను, sir. Now I think we will start, sir. The time is
Okay,
up
sir.
now. We are on YouTube live now.
Okay.
So, welcome, dear participants, for this Pac-Man series, Pediatric Acute Care Management Emergencies, handling the emergencies in the Tier 2 cities and all. So, today we are having this respiratory emergencies in children by Dr. Monica Reddy, who is an assistant professor of pediatrician from AIMS BB Nagar. So before going that, I would like to invite our president, IAP Twin Cities branch, Dr. Subhanakar Reddy sir, to give his welcome remarks, and then hand over it to the Nitin Chavla sir, who is the chairperson and also the founder of this Pac-Man series. Yeah, over to Subhanakar sir.
Well, thank you, Dr. Pawan. Welcome to this ongoing Pac-Man series. Today's topic is pediatric acute respiratory emergencies. This is going to be covered by Dr. Nitin Chavla and Dr. Monica Reddy. And I think this is the most used. We have called last week, we have covered the cardiac emergencies. Now this week we are covering the respiratory emergencies. I think this should be very practical and useful for all the participants. I think you will enrich your knowledge from this series. Thank you.
Yeah, now I welcome the founder of this Pac-Man series, Dr. Nitin Chavla sir, to give the inaugural remarks, as well as tell the new delegates, new participants, how it started and what is the importance of it, what is the certification details also, sir, just as a brief, and then hand
Yes,
over
sir.
to the speaker.
Sridhar, Dr. Sridhar is
Yes,
Dr.
sir.
Sridhar is online.
Yes,
Dr.
Sridhar,
Sridhar
sir.
has joined. Okay.
Yes.
Yeah,
Yes,
I
Sridhar.
respectfully invite Dr. NL Sridhar sir, who is the secretary of Dynamic branch, IAP Twin Cities branch, to give his inaugural remarks before moving to Dr. Nitin sir.
Yeah,
Sir,
sure.
over to you.
Very good afternoon, everyone.
Good afternoon, sir.
Really, I was very overwhelmed with the response, what you are coming forward to share the things. And special thanks to Pawan, who is coordinating very well. And very much special thanks to Nitin, who is made these many sessions possible. And you know very well, Pac-Man is nothing like pediatric acute care management series with a vision, proper vision, improving pediatric emergency skills for the routine practitioners and also intensive care doctors. And today's emergencies, respiratory emergencies in pediatrics is the topic where you come across when compared to cardiac, respiratory, most of the cases, 70 to 80% in our routine practice and in hospital admissions also, most of the cases will be respiratory emergencies only. So I think these 2 hours of 1 hour of thorough session definitely will help you out in applying in your practice and in hospital admissions. See you. All the best for all the people who had enrolled this Pac-Man. Thank you. Thank you, one and all.
Thank you, sir.
Thank you, sir.
So,
Thank you, Nitin sir. Give a overview of Pac-Man series, delegates and their importance. Yes.
I am very thankful to Subhanakar sir, Sridhar sir, Pawan sir for their guidance to make this Pac-Man Pediatric Acute Care Management series see the light of today's day. And I'm very proud to say that with this series, we are able to connect with more than 3,000 pediatricians all across India under with support of IAP Twin Cities. The plan for doing a hands-on workshop during Pedicon is already in place. With a lot of education, there are a lot of skills which are needed, and we as pediatricians are bound to see common emergencies which, if managed well, can actually improve the mortality status of our country and morbidity for the patient at the same time. With respiratory emergencies, our core objective is to understand the physiology, understand the basic necessary steps, and I'm very glad that Dr. Monica from AIMS BB Nagar has taken this task at a very short notice. And as I am confident that what we are going to see in upcoming 1 hour will definitely improve our understanding on the subject of respiratory care in pediatrics. It will help us to understand the basic level of care to advanced level of care in respiratory emergencies till respiratory failure. So let us enjoy the session, and thank you all the seniors, all faculties, all the chairpersons who have been helping to help us teach all the people in India. Thank you. Monica ma'am, please share your slides. Yeah. Let's start, madam.
Okay, so the slide is visible, right?
Yes, madam.
So I thank the organizers for giving me this opportunity to take the session. So in today's session, we will be discussing about common pediatric respiratory emergencies. So we'll just start with a couple of cases. So we have a 3-year-old Ria who presented with fever and cough for 2 days and rapid breathing for 1 day. And at presentation, she had a respiratory rate of 56 per minute and recessions are present and room air saturation was 86%. We have another child, 10-year-old Hirsch, who presented with fever and vomiting for 2 days, seizures and altered sensorium for 1 day. And at presentation, he had a respiratory rate of 36 per minute, rapid and deep breathing. Airway was unstable and he had a lot of oral pooling of secretions. The saturation was again 86% in room air. So if we see these two cases, there are some similarities in the sense that both seem to have respiratory involvement and are presented like a respiratory emergency. Both the children are tachypneic and have some increased work of breathing, and also room air saturation is 86%. However, if we pay attention, we can see that the possible pathophysiology and etiology in these two cases is likely different. The first child seems to be having lower respiratory involvement, lower respiratory illness, whereas the second child seems to be having a neurological illness because of which this child now has a respiratory compromise. So whenever we are approaching respiratory emergencies, it is important to remember that irrespective of the etiology, basically there is a common pathophysiological pathway because of which ultimately there is a respiratory compromise either in the form of respiratory distress or respiratory failure, and this may further progress to cardiorespiratory failure and cardiorespiratory arrest. Hence, it is very important to have a structured approach to respiratory emergencies. We also need to think of the possible etiology at the back of our mind, but the first and foremost step would be to stabilize the patient and then go for definitive management. So in this session, we'll be talking about pediatric respiratory anatomy and physiology. What are the unique features? How do we differentiate between respiratory distress versus failure? Clinical features of various types of common respiratory emergencies, and some common pediatric respiratory problems and their management. So coming to pediatric respiratory anatomy and physiology, so there are several differences as compared to the adult. If we start with the airway, so this is a picture showing the differences between the pediatric and the adult airway. So here if we see, if we go from the top to lower down, the shape of the head in the children is much larger as compared to the facial structure. So the occiput is much more rounded and protruding, and also the nostrils are very narrow, and newborns and even children, infants up to the age of 3 to 4 months are obligate nose breathers. Also, we can see that the tongue is relatively large for the mouth. So the tongue occupies more space in the mouth as compared to the adult. Again, this can predispose to easy respiratory obstruction. The epiglottis is large, omega shaped, and is floppy. The larynx is placed much higher in the neck at the level of C2, C3 and is more anteriorly placed. This again has implications when we are doing endotracheal intubation in choosing the type of the laryngoscope and doing the maneuvers to visualize the airway. The vocal cords are placed slantingly and they slant anteriorly. The neck is much more short, and the narrowest part of the airway is at the level of the cricoid ring as compared to the adults. So these are some of the features which predispose the children to early respiratory obstruction and also difficulties during endotracheal intubation. So here, if we can see in this picture, so the adult airway is almost cylindrical. Whereas if you compare it with the pediatric airway, it is somewhat like a funnel shape, and the narrowest region is supposed to be at the level of the cricoid cartilage, which is subglottic. So even if we are able to visualize the airway up to the level of the vocal cords and try mechanical endotracheal intubation in these children, sometimes we may encounter obstruction beyond the level of the vocal cords at the level of the cricoid cartilage. And also when head positioning, we need to take care in these children. So here again, if you can see in the infant, the occiput is much larger and rounded. So if we place the infant flat on a surface, usually it results in flexion of the neck and resulting in upper airway obstruction. Hence, we need to put a roll under the shoulders to extend the neck appropriately so that the all the respiratory axis come in alignment and there is no respiratory obstruction. Whereas in a slightly older child, it is a different scenario. So in older child and in adults, whenever they're made to lie flat on a surface. So in the neutral position, again, the neck is sort of flexed, resulting in upper airway obstruction. So here in these children, we need to put a roll under the head to elevate it slightly to bring it into what we call as a sniffing dog position. So there is some flexion at the neck followed by some extension at the head. So this sniffing dog position helps in alignment of the oral axis and the pharyngeal axis and the tracheal axis to bring them in a common line so as to open up the airways. Going down further, there is also issue with the airways in the children, where they are easily prone for airway narrowing in the case of any disease. So, if you see this example, if we say that the infant's airway diameter is around 4 millimeters, whereas compared to the adult diameter of, let us say, 8 millimeters. Now, suppose this child has a upper airway or the lower airway problem, because of which there is inflammation, edema, and even a 1 millimeter increase in the edema can result in significant decrease in the cross-sectional area. With 1 millimeter radius or 2 millimeter reduction in the diameter, the cross-sectional area has come down by almost 75% as compared to 44% in the adult. And if we can remember our Poiseuille's formula, we know that the resistance to the laminar flow of the air across the airway is inversely proportional to radius power 4. So because the radius has come down by 1 millimeter, the resistance to the airflow has gone up by 16 times. This is for the laminar flow. So in a normal breathing, the air flows is laminar and the resistance is inversely proportional to radius power 4. However, if the child is agitated or crying or anxious, because of the turbulent flow in the airway, the resistance now becomes inversely proportional to radius power 5. So whenever the child is agitated, the resistance to the airflow is much higher. So this again example shows why these children are much more prone to airway obstruction in various respiratory illnesses. Then coming down further, when we look at the respiratory mechanics, we know that the process of inspiration and expiration is facilitated by the respiratory muscles, the intercostal muscles, and the diaphragm. So when we look at the intercostal muscles, their function depends upon how the ribs are placed. So the lower ribs, from ribs number 8 to 12 onwards, they expand mostly laterally like a bucket handle during the process of inspiration to increase the intrathoracic volume, whereas the upper ribs expand anteriorly like a pump handle. So because of these mechanisms, the intrathoracic volume increases and the air is able to move in. However, if we look at infants, they are at a disadvantage with respect to these respiratory mechanics because the shape and flexibility of the infant chest is still not very well developed. And if you look at the adult chest here in this picture, the shape is more or less cylindrical or rounded, whereas the infant chest is like sort of a triangle, and the ribs are placed more horizontally. Hence, the expected advantage that we the advantage that we expect by the bucket handle mechanism is often lost in these children as the ribs are placed horizontally. And also, the diaphragmatic muscle is still immature, and its function is immature, putting them at increased risk of respiratory failure in case of any illness. So the same can be explained in this picture. So the multiple mechanisms which predispose them to respiratory illness and respiratory distress and failure. The chest wall is much more compliant because again the ribs are not fully ossified and the muscles are not fully developed. Normally when we breathe, normally during expiration, the abdomen and the chest both together move out. During inspiration, both move out, while during expiration, both move inwards. This is normally what we see in older children and in adults. Whereas in infants, because the chest wall is very compliant, in the phase of expiration, it is not able to maintain its normal shape. And during this phase, the chest wall may collapse. And also during inspiration, as the diaphragm is contracting, because of the negative intrathoracic pressure, the chest wall can get pulled inward if the child is in the phase of respiratory failure or the muscles are fatigued. So this again predisposes them to respiratory illness. Also, the increase in the tidal volume is much more limited in children because of the less intrathoracic volume. So they predominantly depend on respiratory rate to increase the mechanical ventilation. So as we know, mechanical ventilation or the minute ventilation is given by tidal volume into respiratory rate. Since the increase in the tidal volume which can be achieved is limited, they predominantly depend on increasing the respiratory rate, again putting them at risk for respiratory distress and failure. Also, the airways are predominantly reactive because of the increased vagal tone, predisposing them to laryngospasm and bronchospasm. And because of the low functional residual capacity and higher basal oxygen consumption, they are prone to rapid hypoxemia. So to summarize, the factors which predispose to rapid respiratory compromise in children include the anatomical and physiological differences, including the smaller airways, increased metabolic demand, decreased respiratory reserve, and inadequate compensatory mechanisms. So with this background, let us see what are the common respiratory emergencies. So as has already been told, the respiratory problems are one of the most common pediatric emergencies that we encounter. And it is also seen that cardiac arrest in children is more often secondary to a respiratory cause than a cardiac cause. So nearly 90% are secondary to respiratory emergencies, vis-a-vis adults, where nearly 90% emergencies are because of a cardiac cause. Hence, prompt recognition and management is very, very important in these children. So if we look at a baby, Anita, who is a 9-month-old baby, she was brought to the emergency room with a 2-day history of low-grade fever, cough, running nose, and 1-day history of rapid breathing. The mother reports difficulty feeding and also whistling sound heard during breathing. On examination, she has a respiratory rate of 60 per minute with lower intercostal retractions, bilateral diffuse wheeze, and 94% room air saturation. The pulse rate is 140 per minute and child was crying inconsolably and had a fever of 1 or 2 degrees Fahrenheit. And this is a video of the baby. So we can see that there are some subcostal retractions, baby is grunting, and also we can hear an audible expiratory wheeze. So whenever any child with such kind of respiratory symptoms presents to our emergency, the first thing that we always do in a pediatric emergency is to triage these patients to see what is the physiological categorization and what is the triage level, which again determines the type of intervention and the speed of our interventions. So whenever we are looking at the triage, so we know that the first component is the initial impression or the pediatric assessment triangle, where we look at 3 components: the consciousness, work of breathing, and color. This is followed by pentagon assessment or the detailed ABCDE assessment, where we again look at the various components of the airway, breathing, circulation, disability, and exposure. So finally, based on these features, we categorize the physiological derangement. So in case of respiratory issues, the derangement, the severity of the derangement may be either respiratory distress or respiratory failure. Depending on this, we triage them into various levels. Either we can follow a 3-level triage or a 5-level triage. Depending on that, either resuscitation, emergency, or urgent or non-urgent. So when we encounter these kind of children, in our initial impression, what are the various features which we may encounter in case of respiratory emergencies? So we know this initial impression is basically to quickly identify conditions that would require immediate and life-saving interventions. This may be in the form of acute upper airway obstruction or tension pneumothorax or an impending respiratory arrest or any other acute life-threatening emergency. So in children with respiratory emergencies, in appearance, we may find that the child is restless, agitated, or combative, or the child may be somnolent or lethargic. So these are basically the manifestations of the air hunger and hypoxia. And over a period of time, as respiratory distress progresses to respiratory failure, so the child may become more lethargic, manifesting the effects of hypercarbia and respiratory fatigue. In terms of breathing, we may notice that the child is tachypnic, has an increased work of breathing, and also we may come across some abnormal airway sounds. In circulation, we may find that the child has pallor or has an ashen color or cyanosed. So these are the components which we can make note of during the initial impression to identify if there is any life-threatening problem and then proceed further. So on further assessment, we may be able to notice several features of respiratory distress. So basically, these are compensatory mechanisms which come forward in case of respiratory illness to maintain adequate oxygenation and ventilation to meet the body's metabolic demands. So we may see it in the form of increased rate and work of breathing. So both these together help in increasing or maintaining the minute ventilation to take care of the oxygenation and ventilation. So often, tachypnea is the first physiological response to any respiratory pathology, except in cases of severe neuromuscular weakness or CNS depression, where we may not see tachypnea and the child may directly present in respiratory failure with bradypnea. So the increased work of breathing is basically because of the use of the accessory muscles of respiration. So we may notice it in form of chest wall indroins, which may be suprasternal, intercostal, subcostal, or sternal. So the level of the chest wall indroins can give us a clue towards what could be the underlying pathology. We would also discuss that shortly. And the child may present with nasal flaring. This is nothing but increased widening of the ala nasae during inspiration, again because of the use of accessory nasal muscles for respiration. We may also notice head bobbing. So head bobbing is again commonly seen in respiratory illness in infants, young infants, and maybe children up to the age of 2 to 3 years. So where during inspiration, the head and the chin move forward, and during expiration, it moves backward. This is again because of the use of the accessory muscles of respiration in the neck. We may also see the seesaw breathing or paradoxical breathing, which I had discussed, wherein during inspiration, the chest moves in and abdomen moves out paradoxically, whereas both should be concordant in normal people, in normal physiology. Whereas here there is paradoxical movement, and during expiration, when the abdomen goes in, the chest is coming out. So this kind of seesaw or paradoxical breathing we may see either because of increasing fatigue, so respiratory distress progressing into respiratory failure, or because of the weakness of the respiratory muscles. Another important feature of increased work of breathing is grunting. So grunting is a specific sign which we usually see with alveolar involvement and sometimes also with the involvement of the terminal bronchioles and respiratory bronchioles. So basically, it is again a compensatory mechanism being employed by the child to keep the alveoli open at the end of expiration and to prevent them from collapsing. So the child will try to breathe or expire against a partially closed glottis, which results in the production of a specific sound, which we call as grunting. So this is basically to generate some peep to keep the alveoli open during the phase of expiration. So tachypnea can be classified. There are various. You can find various tables giving the limits of upper and lower limits of respiratory rate according to various age groups. But the simplest one to remember is the WHO criteria for tachypnea, where in children more than 0 to 2 months, more than 60 per minute is taken to be tachypnea. Children between 2 to 12 months, respiratory rate more than 50. Between 1 to 5 years, rate more than 40, and more than 5 years, rate more than 30. So these are the cutoffs which we can easily remember. And any respiratory rate less than 10 per minute in any child of any age group is bradypnea. So what are the other common features we can find on ABCD assessment or detailed examination in these children? One is we need to note the position of the child. So because of the obstruction at different levels in the respiratory tract, the child may assume different positions to keep the airway open. And this we will call as the position of comfort, which best supports their respiratory effort to maximize the airway opening. So here in this picture, we can see this child is sitting in a tripod position. So the child is leaning forward, supporting the weight over his upper limbs, and also the chin is slightly tilted up. So this kind of position again helps in keeping the airway open in case of upper airway and usually lower airway obstruction. So we may also see this in children with asthma. And the other common position which we see is the sniffing dog position, where again to keep the airway open, the child may slightly flex at the neck and extend at the head level. Also, we may come across various abnormal sounds on examination. So these may be in the form of stutter or snoring, wherein there is obstruction at the oropharyngeal level. Gurgling sounds are because of the, again, pooling of the secretions in the oropharyngeal region. Stridor is characteristic of upper airway obstruction. So classically, stridor is described as a harsh inspiratory sound. So it is predominantly seen during inspiration, wherein the obstruction is usually above the level of the vocal cords. And grunting can, we have already discussed, can be because of obstruction at the alveolar level or the lower airways. Wheezing is usually a feature of lower airway obstruction, and it is described as a soft musical sound predominantly seen in the expiratory phase of respiration. Crackles are characteristic of alveolar involvement. So based on the various features which we see in our ABCD assessment, we may be able to differentiate whether the child is having respiratory distress or respiratory failure. So as I've told, whenever there is a respiratory problem, we need to determine what is the severity of that respiratory problem, whether it is distress or failure. And we will also need to determine what is the type of the problem, which we'll come to shortly. So the distress and failure, so based on the airway. So if the airway is open and maintainable, it is likely to be in respiratory distress. Whereas in respiratory failure, you may notice that the airway may not be maintainable if the child is unconscious or because the child is hypoxic. Usually, we will see tachypnea and increased work of breathing, but reasonably good air entry in respiratory distress. Whereas in respiratory failure, the child can have marked tachypnea or may go on into bradypnea and apnea, or the child may have irregular breathing and decreased respiratory effort and poor air entry. In circulatory component, in respiratory distress, we may see tachycardia and maybe pallor. Whereas in respiratory failure, we may come across marked tachycardia or going into bradycardia, which is nothing but impending cardiorespiratory arrest. And also the child may appear cyanosed. In disability, in respiratory distress, the child will be usually irritable, anxious, and agitated. Whereas a child who is lethargic and unresponsive is likely in respiratory failure. Similarly, on exposure, we may find pallor in respiratory distress and cyanosis and variable temperature in respiratory failure. So basically, we have seen that the features of respiratory distress are nothing but the compensatory mechanisms. So whenever these compensatory mechanisms are failing or have exhausted to maintain the gas exchange, the child moves from respiratory distress into respiratory failure. It is important to remember that respiratory failure may occur without respiratory distress in case of usually neurological problems, either because of respiratory depression because of poisoning, or there may be some brain dysfunction, or it may be a peripheral neuromuscular failure like a neuromuscular paralysis or respiratory muscle fatigue. So in these children, we may not see the phase of respiratory distress and the child may directly present in respiratory failure. So any child who has been in respiratory distress if we notice that the respiratory rate is falling and the heart rate is falling, however, the child is becoming more lethargic, then it is definitely not an improvement, and this is an impending sign of respiratory failure and cardiorespiratory depression. Then coming to the type of the respiratory problem. So based on based on where the pathology or the etiology is, the respiratory emergencies can be divided into 4 types. So the first type is upper airway obstruction or a lower airway obstruction or lung parenchymal disease or disordered control of breathing. So again, based on our examination ABCDE assessment, we will be able to determine what is the type of the respiratory problem and where the likely pathology is. So in case of upper airway obstruction, we generally see suprasternal and supraclavicular retractions, and the obstruction often worsens in inspiratory phase. They may also be noted to have prolonged inspiration. The extent of tachypnea may be less in children with upper airway obstruction as compared to other types of respiratory emergencies. The other features which point towards upper airway obstruction include the presence of stridor, which we have seen is usually an inspiratory sound. The child may have a barking cough, hoarseness, stutter, or hot potato voice, or they may also present with drooling or dysphagia. So presence of any of these points towards the possibility of an upper airway obstruction. In lower airway obstruction, we generally see subcostal and substernal retractions. The obstruction is worse during expiration, and also we may notice prolonged expiration. Wheeze, typically expiratory, is characteristic of lower airway obstruction, and also we may find a hyperinflated chest because of dynamic hyperinflation, air trapping and dynamic hyperinflation. In lung parenchymal disease, we generally see intercostal retractions, and the presence of grunting and crackles or crepitations is characteristic. In those with disordered control of breathing, either due to a central or a peripheral neuromuscular failure, they often present with decreased work of breathing. As we have seen, they present directly with respiratory failure, or they may also demonstrate an abnormal respiratory pattern like a Chine-Stokes breathing or an ataxic breathing. And they may have conducted sounds and auscultation. This is basically because of the pooling of the secretions and the upper airway sounds being conducted to the chest. So in all these cases, we may also find other features of airway obstruction indicating severity of the problem in terms of it may present in the form of poor air movement, lack of chest rise, asymmetry, or even absent or faint breath sounds. So any child who is presenting to us with a pediatric emergency, we need to do the triage, the initial impression, and the ABCD assessment. We need to, if it is a respiratory problem, we need to categorize in terms of the severity of the problem, whether it is distress or failure, and in terms of the type of the problem, upper airway obstruction, lower airway obstruction, parenchymal disease, or disordered control of breathing. So once we are clear, we need to identify what are the derangements which require immediate attention and do the appropriate interventions. During the same time, we may also think about what diagnostic studies may help us in the management. So diagnostic studies should be done only when indicated in children with acute respiratory distress. So most of the times, the initial stabilization takes precedence over diagnostic tests as they may not provide much specific information than what we already have from the clinical history and examination. So in some of these cases, there may be an indication to do a complete blood counts, especially in CRP, especially when we are suspecting infections. We may need to do serum electrolytes and renal function tests because many of these children, because of the respiratory distress and failure, may also be dehydrated. So it may be important to look into serum electrolytes and renal function tests. Blood gas analysis will give us information regarding the oxygenation and ventilation status, and also the whether there is any component of acidosis in terms of low pH. Viral studies may be indicated in some of these children. Chest X-ray is usually indicated in all children with significant respiratory distress and those with any focal lung findings on examination. Lateral X-ray may sometimes be required in some of these children with upper airway obstruction, for example, in cases with epiglottitis, retropharyngeal abscess. Point of care lung ultrasound is lately being used in emergencies to help in the diagnosis and management of these patients. CT and MRI may be rarely required to come to a specific diagnosis in cases of respiratory emergencies. For example, in a retropharyngeal or a parapharyngeal abscess, when we are suspecting to know the severity of the obstruction and the extent of the abscess, CT may be indicated. It is very important to recognize and remember that no diagnostic procedure should be done before definitive airway management. So wherever there is feature of especially upper airway obstruction, these children can progress and collapse very rapidly. So they need to be kept calm. So first we need to stabilize the airway before we go for any diagnostic procedures. So how do we manage these patients? So the general principles of management: keep the child as calm as possible with the caretaker in the position of comfort. So we have seen that agitation and crying makes the airflow turbulent, and also the airways tend to collapse further during agitation and crying. So all of this results in increasing the airway resistance and increased work of breathing. So always try to keep the child calm and keep the child with the caretaker and minimize interventions as much as possible. Support the airway breathing and circulation. Suction and airway maneuvers may be used wherever required. Again, remember to do suction gently and only as and when required, and not to do any vigorous suction and disturb the child. Airway maneuvers like head tilt chin lift maneuver, jaw thrust maneuver may be required in some cases of upper airway obstruction. Majority of these children with respiratory distress and failure will require a humidified supplemental oxygen. This should be provided in a non-threatening way. So wherever the child is not tolerating either the face mask or the nasal prongs, sometimes we may have to give them a blow-by oxygen without disturbing them much in a non-threatening way. If there is a need for higher FiO2 and any positive pressures, we can consider non-invasive techniques like CPAP or hypronasal nasal oxygen therapies. Some of these children will require positive pressure ventilation, especially when we are unable to overcome the airway obstruction with other measures, or if the child is already in respiratory failure where the effort is not adequate, the spontaneous efforts are not adequate. So in these children, we may require to use bag mask ventilation or do an endotracheal intubation and back tube ventilation. It is very important to have a continuous ongoing monitoring in any child presenting with respiratory emergency, because the situation can be quite dynamic and sometimes they progress very rapidly. So this is a picture just demonstrating the head tilt chin lift maneuver and the jaw thrust maneuver. So in the first set of pictures, you can see the head tilt chin lift. So basically the provider stands on the side of the patient and puts one hand over the forehead to extend the neck slightly. And using the fingers of the other hand, he pulls the jaw forwards and outwards, downwards and outwards, so that the lower incisors come ahead of the upper incisors. So this is called as the head tilt and chin lift maneuver. So by doing this, the tongue is pulled forward and outward, and it helps in opening up of the upper airway. However, in children with suspected cervical spinal injury, this maneuver is contraindicated as it may aggravate the injury further. So in these patients, we may have to use jaw thrust maneuver. So here you can see you are stabilizing the neck in the neutral position and not doing any extension or flexion of the neck. So the provider stands at the head end of the patient and using both the hands while stabilizing the head in the neutral position, he tries to push the jaw forwards and outwards to open the airway. Once we have done these interventions to stabilize the patient, depending upon the specific problem, further specific interventions may be required. For example, in cases of medical upper airway obstruction, like in viral flu, the child may require nebulized budesonide or an injectable steroid. In case of mechanical upper airway obstruction like foreign body, specific measures like back slap, chest thrust or Heimlich maneuver are indicated. In case of partial diphtheria, you will have to administer an antidiphtheritic serum or may have to go for a tracheostomy. In case of lower airway obstruction, for example, in acute severe asthma, bronchiolitis, the child may require inhaled short-acting beta agonist bronchodilators. In case of lung parenchymal disease with bacterial pneumonia, antibiotics should be initiated. And in cases of disordered control of breathing because of a neurological illness, there may be a requirement for using anticonvulsants if the child has seizures, and also to go for advanced airway and mechanical ventilation. So depending on the specific problem, we may have to also address these issues and provide specific interventions. So that was basically to give an introduction about various respiratory emergencies and how to approach these children. So now we will discuss some of the common emergencies that we encounter in children. So in a child, so first we will discuss about the upper airway emergencies. So in a child presenting with features of upper airway obstruction, we'll have to see if the child is having any high fever or toxic appearance, or and whether the illness is acute in onset. If yes, and if the child is having a stiff neck, then it is likely to be a retropharyngeal abscess. In children with high fever, toxic appearance, but no stiff neck, could possibly be cases of bacterial tracheitis or epiglottitis. Since the advent of the Haemophilus influenza vaccination, we rarely see epiglottitis these days. In a child presenting with acute onset upper airway obstruction or low-grade fever, but not having toxic appearance, this child may be a case of either a peritonsillar abscess or an infectious mononucleosis, or especially more commonly we see this to be croup or acute, what we also call as acute laryngotracheobronchitis. So these children have a gradual onset with low-grade cough, and they present with barking cough and rhinitis and hoarseness suggestive of viral illness. In children with chronic progressive stridor, especially if there is any associated congenital anomalies, we may have to think of any anomaly resulting in upper airway obstruction. Other not so common causes may be because of trauma whenever there is blunt penetrating injury to the neck, or because of smoke inhalation or caustic ingestion, or even cases of airway foreign body or angioedema or anaphylaxis. So these are all common examples of respiratory emergencies presenting with upper airway obstruction. So again, just to reiterate, in children coming with fever, croup can present with mild fever. The child may be having peritonsillar, retropharyngeal or parapharyngeal abscess, or it may be a case of epiglottitis or bacterial tracheitis or diphtheria or infectious mononucleosis. So these are all basically the infectious causes of acute upper airway obstruction. So there can be non-infectious causes like inhaled foreign body, hypocalcemia, angioedema, congenital airway anomalies, subglottic hemangioma, and even neurogenic stridor. So in a child coming with croup, the presentation is quite classical. However, we need to consider alternative diagnosis if any of the red flag signs are present. For example, very sudden onset within minutes is often suggestive of a foreign body obstruction rather than croup. Presence of high-grade fever, toxic appearance goes more in favor of bacterial infections like an abscess or an epiglottitis. In the presence of a biphasic stridor, prolonged stridor, or recurrent stridor, again, we may have to consider some other airway anomalies resulting in upper airway obstruction. The presence of wheezing or rales. Sometimes we may see wheezing in cases of croup also, since it is acute laryngotracheobronchitis, and they may also have some component of bronchiolitis. However, if the wheezing is much more prominent than stridor, then it is unlikely to be or less likely to be croup. Presence of drooling, difficulty swallowing, trismus, torticollis again points towards other causes of upper airway obstruction. Presence of facial or neck swelling, maybe because of in cases of angioedema, or even in case of diphtheria, we may see neck swelling. Presence of skin rash, erythema, shock, age below 3 months, and poor response to management, especially the steroids and the inhaled steroids, goes against the diagnosis of croup. So croup is generally classified based on the Wesley Croup score, where a score of less than or equal to 2 is considered to be mild croup. If the score is 3 to 7, it is moderate croup. Score of 8 to 11 is severe croup, and more than or equal to 12 is impending respiratory failure. So for most of the problems in pediatric emergencies, we have these staging criteria which helps us in rapid assessment and to stage these patients into various categories to decide upon the further management. So croup is a clinical diagnosis. X-ray is not indicated for the diagnosis of croup, but I've put this X-ray just to show like what are the findings we commonly see in croup. So in the anterior posterior radiograph of the neck, we see what we call as the steeple sign. So here you can see the trachea is tapering and getting narrowed as we are moving up. So any child presenting with croup, again follow the basic principles. Keep the child as calm as possible with the caregiver. Limit examination. Please do not insert a tongue depressor and try to postpone IV cannulation as much as possible. So especially children with critical croup, any kind of intervention will make them agitated and the child may move from partial upper airway obstruction to complete upper airway obstruction and collapse rapidly. Hence, it is very important to keep them as calm as possible. Again, administer oxygen in a non-threatening way if the child is hypoxic and avoid sedation at all costs in these children unless you have already secured the airway. So, in cases of mild to moderate croup, one can administer a single dose of dexamethasone 0.6 mg per kg IV or oral, or even prednisolone 1 mg per kg oral. IM route is preferred if there is persistent vomiting or respiratory distress. If this is not feasible, budesonide nebulization 2 mg may also be considered. In cases of severe life-threatening croup, administer single dose of intramuscular dexamethasone and also administer nebulized undiluted adrenaline 0.5 ml per kg with oxygen. And it may be repeated after 2 hours if there is poor response or there is recurrence of stridor. Coming to another common upper respiratory emergency is angioedema or anaphylaxis. So in these children, we may see sudden onset of generalized rash, usually urticarial rash, angioedema and flushing and pruritus, and the presence of rapid progression, features of severe respiratory distress, stridor, wheezing and cyanosis, presence of abdominal pain, vomiting, poor perfusion, arrhythmias, hypotension, all these are danger signs and will require immediate intervention. So in any child presenting with anaphylaxis, one needs to take care of the airway. Sometimes immediate intubation may be required if the child is in impending complete airway obstruction, and it has to be always be done by the most experienced person on floor, because we will not have time to make multiple attempts and it will rapidly progress into complete obstruction where we may not be able to establish an airway. So in those cases, cricothyrotomy may be an option to establish the airway. Intramuscular epinephrine is the agent of choice in cases with anaphylaxis. The dose is 0.01 mg per kg of 1 in 1000 dilution with a maximum dose of 0.5 mg per kg per dose, and it may be repeated in 5 to 15 minutes if the response is partial or not, or if the symptoms persist. Child may require administration of oxygen or a saline bolus to maintain the hemodynamics. Glucocorticoids, methylprednisolone 1 mg per kg IV may be considered in severe cases, and we may also consider antihistamines, either diphenhydramine or cetirizine or famotidine in these children. So bronchodilator may be given if the bronchospasm is resistant to epinephrine. So need to remember that intramuscular epinephrine is the agent of choice. So whenever we encounter a child with anaphylaxis, it has to be administered as early as possible. Then coming to common pediatric lower airway emergencies. So the two common emergencies which we see are the bronchiolitis and asthma. So bronchiolitis we know is commonly seen in children less than 2 years of age, especially in infants, and it is one of the commonest causes for hospitalization in infants. It is basically an acute inflammation of the lower airways, resulting in increased mucus production, necrosis, and accumulation of debris and airway obstruction. Commonly seen with RSV, which is responsible for nearly 50 to 60% of the cases of bronchiolitis. The rest of the cases are contributed by various other respiratory viruses, including rhinovirus, metapneumovirus, adenoinfluenza, parainfluenza, etc. The common presentation is an upper viral prodrome where the child initially has cough, coryza, nasal discharge, sneezing for a couple of days. This is followed by fever and respiratory distress and onset of wheezing. So this is the classical presentation. Again, bronchiolitis is a clinical diagnosis. No routine laboratory testing or imaging is required unless the child has severe respiratory distress or is in respiratory failure, or we are suspecting a cause other than bronchiolitis. So risk factors for severe bronchiolitis include age less than 12 weeks, prematurity, underlying comorbidities either in form of cardiac disease, pulmonary disease, neurological disease, or an immunodeficiency or a genetic disease. So the pathophysiology, it is important to understand the natural history of bronchiolitis so as to titrate our interventions and also to counsel the family regarding the course. So usually the overall course may extend from 1 to 2 weeks and sometimes even up to 3 weeks. So as I've told initially, there is a viral upper respiratory prodrome followed by the onset of respiratory distress and wheezing. So once there is respiratory distress, there can be significant minute-to-minute variability in the symptoms, in the sense that the child may appear to be calm and with minimal distress for some time, whereas in couple of minutes or hours, you may find the child to be in severe distress, and they can have this kind of waxing, waning, and fluctuating course. Basically, this is because of the lower airways getting obstructed in multiple regions, and the mucous flux may get relieved intermittently, resulting in this waxing waning kind of symptoms. Eventually, there will be gradual resolution of the symptoms, and often cough may persist for a prolonged period even after the resolution of the respiratory distress. So in the picture, if you can see here, the first picture is the normal bronchial lumen. So there is epithelium and the lumen is open. Whereas if you see the second picture, so the bronchial wall is thickened, the epithelium is edematous, and the lumen is obstructed by various necrotic debris. Bronchiolitis may be classified into mild, moderate, and severe categories, again based upon the extent of the respiratory distress. So in mild bronchiolitis, the behavior is usually normal. The child can have mild tachypnea and mild retractions. The room air saturation is more than 92%. There are no episodes of apnea, and the feeding is not impaired. In moderate cases of bronchiolitis, the child may have some intermittent irritability with increased respiratory rate and increased work of breathing. There may be substernal and subcostal retractions. The saturation will be between 90 to 92% on room air, and they may have difficulty with feeding. Whereas in cases of severe bronchiolitis, they have increasing irritability, or the child may be lethargic. They have marked increase or decrease in respiratory rate with marked retractions, marked nasal flaring. The saturation at room air will be less than 90%. And sometimes the hypoxia may not be corrected by oxygen alone, and these children may require some kind of positive pressure ventilation. And they may also have prolonged episodes of apnea, and they are often reluctant or unable to feed. So based on this clinical findings and based on the room air saturation levels, they can be categorized as such. Regarding the treatment, the most important part is supportive management, adequate hydration to ensure that the child is not dehydrated, and provide adequate nutrition, supplemental oxygen as required. One may consider a trial of salbutamol or hypertonic saline or racemic epinephrine. However, supportive care is the most important mainstay of management. There is currently no evidence or no indication to use therapies like antihistamines or decongestants in children with bronchiolitis. Racemic epinephrine has been shown in case of emergency settings to decrease the risk of hospitalization. So, trial of racemic epinephrine can be given in children with moderate to severe bronchiolitis. There is no defined role of steroids. Hypertonic saline again has been shown in few studies to improve the comfort of the child. Again, the evidence is not very clear. There is definitely no role of antibiotics since this is a viral illness. And the role of suctioning and chest physiotherapy and the use of cool mist is also controversial. So basically, we don't have much evidence-based interventions in children with bronchiolitis, and most of the times it is supportive management. Hence, knowing the natural history is also important to counsel the family adequately regarding the course of the illness. So differentials of acute wheezing in children. can be either because of aspiration syndromes, gastroesophageal reflux, or a underlying cardiac disease, anatomic anomalies causing intrinsic or extrinsic airway obstruction, presence of a foreign body in the lower airway. Usually, in cases of lower airway foreign body, the findings are unilateral. So the child may have only unilateral or focal wheezing, and also it is usually only monophonic wheezing as compared to polyphonic wheezing in children with bronchiolitis. Also, the chest may be showing unilateral findings like reduced breath sounds and hyperinflation. Anaphylaxis, inhalational injury are also other differentials for wheezing in children, and other inherited conditions like mucociliary clearance disorders and immunodeficiencies can also present as recurrent wheezer. So usually bronchiolitis is any first episode of wheezing in any infant or a child up to 2 years of age, and in a well-growing and a normal healthy child. So that is considered to be bronchiolitis. So any recurrent episodes or any red flag signs like failure to thrive, and any other symptoms and signs on examination, one needs to think of other possibilities other than bronchiolitis. So coming to the other common lower airway emergency is the acute severe asthma. It is basically because of chronic airway inflammation resulting in episodic wheeze, shortness of breath, chest tightness, and cough that vary over time and in intensity with variable expiratory airflow limitation. So this kind of variability over time and intensity is characteristic feature of asthma, commonly seen in children between 5 to 17 years of age, though children less than 5 years can also present with recurrent wheezing. We may not be able to establish diagnosis of asthma in these children. Laboratory testing and imaging are again not mandatory for diagnosis and management of acute asthma exacerbation. So in a child presenting with acute exacerbation, uh, even spirometry cannot be done as the child will not be able to cooperate for spirometry. There may be a role for doing chest imaging in case we are doubtful about the diagnosis. However, other than these, any other investigations are not clearly indicated in acute exacerbation. So sometimes investigations may be required to identify the trigger or in case of severe or complicated cases or to identify any alternative condition. So several scoring systems are available to score the severity of pediatric asthma, which can help us again in managing these children in emergencies. So one of the commonly used and validated score is this pediatric respiratory assessment measure or the PRAM score, which classifies these children based on the presence of suprasternal indroins, use of the scalene muscles, the severity of the wheeze, air entry, and pulse oximetry on room air. So based on this, the children can be classified as mild, moderate, or severe cases of asthma, exacerbation of asthma. The presence of respiratory fatigue, hypoxia, bradycardia, absence of wheezing, and altered sensorium indicates severe obstruction and impending respiratory failure. Coming to management, so oxygen is indicated if the child is hypoxic. The agent of choice in the management is short-acting beta agonist, which may be administered either using an MDI with spacer or using a nebulizer. So MDI with spacer may be helpful in children with mild cases, whereas moderate to severe cases may require administration through a nebulizer since they may not be able to use MDI. And also, since these children are usually prone to hypoxia, the nebulization should be oxygen-driven rather than normal air-driven nebulization. Muscarinic ACH receptor blockers like ipratropium may also be considered. There is role of early systemic steroids, especially in moderate to severe cases of asthma, and it has been shown to reduce the hospital admission rate and hospital length of stay. Single dose of intravenous magnesium sulfate may be considered in children who continue to have high PRAM scores even after initial management with steroids and beta agonists. Further therapies can include intravenous salbutamol, aminophylline, or tarbutaline in children refractory to the initial measures. So steroids can be either oral steroids are preferred wherever the child is able to take orally. So it may be in the form of prednisolone or dexamethasone. Or if the child is unable to take, then we may consider intravenous dexamethasone or methylprednisolone. Then the last common pediatric emergency that I would discuss is this foreign body aspiration. So usually seen in previously healthy children, especially in children less than 3 to 5 years old, who present with choking followed by sudden onset forceful cough or stridor. So, however, it is important to remember that nearly 50% of the children with foreign body aspiration may not provide history of choking. Hence, it is very important to have high index of suspicion. So the signs and symptoms are based on the location of the foreign body and the degree of obstruction. So usually if it is in the upper airway, so they will present with features of upper airway obstruction like stridor, suprasternal retractions, and it needs to be removed on in children with hello in children with lower airway obstruction because of the foreign body. So they usually present with unilateral findings in terms of reduced air entry, hyperinflation, wheezing, stridor, or increased wheezing or increased work of breathing. And the clinical features may also change with the changing positions. So sometimes these children, where there is no clear-cut history of foreign body aspiration, they may present as recurrent wheezer or recurrent pneumonia. Hence, it is important to have a high index of suspicion. So this is one X-ray showing possible foreign body obstruction. So here we can see that the right side of the chest is hyperinflated and the mediastinum is pushed to the left side. So this is possibly because of the presence of the foreign body in the right bronchus, resulting in obstruction and air trapping. So sometimes these kind of clear-cut signs may not be visible, and we may have to go with secondary signs like opacification or the presence of distal atelectasis. So in the second X-ray, again, there is possible obstruction on the left side. So the management in case of partial airway obstruction, if it is in the upper airway and it is partial obstruction, do not intervene, just keep a close watch. Encourage the patient to cough out because the patient's forceful cough is the best measure to bring out the foreign. However, in case of complete airway obstruction, so this we know by demonstration of the universal choking sign, or the child is unable to cough or vocalize, or if there is cyanosis. So in these cases, in a infant, if it is an infant and the infant is conscious, we use alternate 5 back slaps and 5 chest thrusts, continued further till the foreign body comes out. In a child who is conscious, we use abdominal thrust. Whereas in an unconscious child, we immediately start cardiopulmonary resuscitation. We need not check for the pulse in these children because any child with a foreign body, with a complete airway obstruction due to foreign body and the child is unconscious, we directly start chest compressions because this helps in forcing out the air and removing the foreign body. So whenever we are going from compression to ventilation, we should always open the mouth for any visible foreign body, remove it with the finger if possible, and then continue the compressions. So bronchoscopy is both therapeutic and diagnostic in these children. Wherever there is asphyxia, clear-cut radio-opaque foreign body, or a clear-cut history of foreign body aspiration, or we have clear-cut features like unilateral decreased breath sounds and chest X-ray findings, then we can directly go for rigid bronchoscopy to remove the foreign body. Whereas if the diagnosis is not clear and there is only a suspicion, one can consider flexible bronchoscopy initially for diagnosis, and if possible, we can remove the foreign body using flexible bronchoscopy, or this can be followed by rigid bronchoscopy for the removal of the foreign body. So that brings us to the end of the common respiratory emergencies. So my take-home message would be that anatomical differences put children at greater risk of airway obstruction, while physiological differences make them more prone to hypoxemia. A structured ABCDE approach is essential to identify both the type and the severity of the respiratory problem and to intervene appropriately. Clinical clues help in categorizing the severity and the type of the problem. Clinical features rather than laboratory evaluation are sufficient to establish the diagnosis in most of the children with respiratory emergencies. Hence, stabilization of these parameters should take precedence over diagnostic evaluation, and continuous ongoing assessment and monitoring is paramount in the management of these children. Thank you.
Thank you, Dr. Monica, for such a lucid presentation. I firmly believe that if we identify respiratory emergency in right time, we act immediately, and like you have mentioned, objectively assess the patient, we can actually save many lives with all the resources whatever are present at our setting, and we can definitely bring in changes in life of many sick children. I think we will take all the questions in the group, and I will add Dr. Monica in the groups, so that if at all you are facing any challenges in assessment or management, you will be able to talk to Dr. Monica and all other experts who are part of the group. Thank you, Dr. Monica, for taking out time from your schedule and doing this presentation, and thank you everyone for joining. We will end this session now.
Yeah, thank you, Monica ma'am. Thank you so much, Indian Academy of Pediatric Twin Cities branch. From their side, I'm expecting my gratitude for wonderfully presenting the most common topic in a very lucid and very, it was very effective way. Thank you so much. Thank you so much.